Hello everyone. Pancreatic neuroendocrine tumors are rare, but they are clinically fascinating entity. One patient may present with recurrent hypoglycemia and seizure, another with refractory peptic ulcers, another with liters of watery diarrhea, and another with silent pancreatic mass with liver mets. The key to understanding PNETs is simple. First, decide whether the tumor is functional or non-functional, then localize it, grade it, stage it, and plan the treatment. In this video, we will simplify the PNETs for medical students and trainees. So this is a very basic level talk meant for the trainees and basically medical students, from clinical presentation to investigation, prognosis and management. So theoretically, then some case discussion and questions, so that this will be a comprehensive video covering all the aspects of PNETs. Please read the detailed disclaimer and description. These videos are meant for education purpose only, and these are not a substitute for professional training and professional advice. And friends, for an exclusive and early access to our premium high definition content, please download our app Android or iOS or join the channel membership. The link for everything is given in the description of this video. Please check it out. Let's start with this PNET episode, Clinical Features, Investigation, Prognosis, Management 2026 update. The next PNET we will discuss will be somatostatinoma. So basically it is an inhibitory hormone. Inhibits hormone secretion, growth hormone, insulin, glucagon, TSH, slow digestive process, gastric acid, enzyme secretion, intestinal motility, reduce blood flow to the digestive organs. So somatostatinoma, everything becomes static with this statinoma. So excess of the somatostatin leads to diabetes mellitus because it is inhibiting the insulin secretion. Gallstone formation is basically more because of the reduced gallbladder motility that also is decreased because of this effect. Steatorrhea because reduced pancreatic enzyme secretion and fatty stools. So somatostatinoma, steatorrhea, stones, sugars. So there are multiple S: somatostatinoma, steatorrhea, stones, and sugars. Just remember, this may be a multiple choice question again. So as I said, the somatostatin is basically inhibitory hormone derived from somato, body, and statin means stopping or inhibiting from stachys, so causing to stand still. So somatostatin is an inhibitory. It makes everything static, secreted by the islets, D cells from the pancreas, hypothalamus, and D cells of the GI tract. Somatostatin inhibits insulin, glucagon, gastrin, and BIP. So basically all the hormones so far we discussed, that is insulin, glucagon, gastrin, BIP, they are basically inhibitor. This is the inhibitor of all the hormones. So it is a static broad inhibitor. So that means if something is being produced more, it will inhibit the function of that hormone. So that means the somatostatin becomes automatically a pharmacological analog like octreotide, useful therapeutic agents in the treatment of all these PNETs. And you will understand while we will discuss this therapy like PRRT in the subsequent part of this video. The next or last PNET will be pancreatic polypeptide secreting PNETs. So they secrete pancreatic polypeptide, extremely rare. Whether should be classified as functional is a matter of debate because no specific syndrome has been defined or associated with the oversecretion of this PP hormone. Patient may present with intermittent abdominal pain, pancreatitis, and may develop glucose intolerance. ME1, they tend to be multifocal and malignant. So how to investigate these PNETs? So friend, the principle of investigation is simple for the functional PNETs, that you have to basically look for the hormone that produce like insulin, serum insulin, C-peptide, proinsulin during hypoglycemia. And for gastronoma, fasting serum gastrin level more than 1000 picogram per ml and gastric pH. We got diagnostic, glucagonoma, elevated fasting glucagon levels, bipoma, elevated plasma BIP levels, and for somatostatinoma, elevated plasma somatostatin level. For non-functional PNETs, the chromogranin A is non-specific, but usually it is a helpful adjunct and helpful tumor marker for the non-functional PNETs, and you should always look for it. So what are the imaging required for diagnosis? So first line investigation will be CT scan, triple phase or MRI. That is the first line imaging modality to detect size, location, metastatic spread of tumor. Look for liver mets, which are common. PNETs, pancreatic neuroendocrine tumors, are hypervascular, best seen in the arterial phase. Just remember this thing, that they light up in the arterial phase. So always look for these tumors in the arterial phase and look for the enhancement pattern. If despite all the measures we are not able to localize the tumor, then the angiography is very good modality for preoperative localization, or in case where imaging is inconclusive, PNETs are hypervascular, appear as a tumor less on the angiography as shared in these pics. So this is the basically diagnostic imaging ladder. Ultrasound, maybe CT scan, MRI, first choice. Endoscopic ultrasound, it has a advantage that you provide the tissue diagnosis also. Disadvantage is inclusive. SSR, somatostatin receptor study, they are outdated. Now the DOTA or DOTA TET, DOTA PET scan, they are the gold standard. And last is the angiography if rest of the modalities are inconclusive. The final diagnosis is with the biopsy, that is obtained from the US or FNA percutaneous route, and IC is confirmatory, that is you look for the specific ISC marker like chromogranin A for these tumors. So again, this is very important slide in the diagnostic ladder, friends. Just try to understand that the well-differentiated pancreatic neuroendocrine neoplasm, pancreatic neuroendocrine tumors, PNETs, they are basically three grades. Grade 1, when the Ki67 index is less than 3 and mitotic indexes on histophysiology is less than 2. So on ISC less than 3, less than 2. Grade 2 is 3 to 20 is Ki67 and 2 to 20 is mitotic index. So in mitosis size is 2 and on the Ki67 it is 3. For grade 3, it is more than 20 and more than 20 proliferative index and more than 20 is the mitotic index. So next term is pancreatic neuroendocrine carcinoma, that will be grade 3. So P always confuse between the pancreatic neuroendocrine carcinoma and pancreatic neuroendocrine tumor grade 3. So what is the difference? So when the architecture is preserved, then we grade it according to the pancreatic neuroendocrine tumor grade 3. For when the architecture is lost, when the histopathologist or the pathologist will say, it is basically there's no clear picture whether it's an adeno or it is a neuroendocrine, I cannot say. So then it is usually a picture of the neuroendocrine carcinoma. So that will be grade 3. There are no other grades for NEC. They are basically two types, small cell type and large cell type. In both these scenarios, the Ki67 and the mitotic index is more than 20. So you can pause this slide here and try to understand the difference between the NET grade 3 and NEC grade 3. To the fourth case, friends, this is a rare presentation. So 45-year-old lady presented with rash, weight loss and new onset diabetes. So if you have gone through the video so far, you should be able to make the diagnosis with these two lines only. She complains of itchy erythematous rash on her lower abdomen, thighs, unintentional weight loss, polyuria over past 6 months. There was a rash, polyuria and unintentional weight loss. I hope you could make the diagnosis. This was something similar to the case which was published in NEGM, which we have discussed, that is the necrolytic migratory erythema specific rash with diabetes mellitus. Polyuria was because of the diabetes mellitus and unintentional weight loss. So this is a basically case of glucagonoma. So these were the investigation. Fasting blood glucose 189, mildly elevated. Serum glucagon level was 1500 picogram per ml, elevated. Skin biopsy rash shows necrolytic migratory erythema. Imaging MRI abdomen shows 3.5 centimeter mass in the pancreatic body. So the diagnosis is glucagonoma. So we did the surgical resection for this patient. The diabetes was managed with the help of insulin in the pre-op stage. Nutrition was improved. Post-op stage, glucagon level normalized, rash resolved, and diabetes was well controlled post-surgery without insulin, and the rash did not occur. So the key points for glucagonoma is it's a rare PNET, extremely rare. I think less than 400 cases reported so far in the literature. There is a characteristic rash, necrolytic migratory edema, and weight loss, mild diabetes. Recognizing skin manifestation lead to the early diagnosis. So, like in this case, the skin biopsy of necrolytic migratory edema was diagnostic. So now, friends, this is the end of the discussion. After that, we will discuss. I'll share some multiple choice questions. You can attempt. These are basically simple, basic level questions. They will help to basically strengthen the concept. I mean, I have given the answer and the explanation also. You can always pause at the question level, think of the answer, then go for the answer, so that you strengthen your basically basic knowledge or the understanding of these PNETs better. If there is any doubt, you can always go back to the original part of discussion and see again and again solve these questions. So if you have any doubt or any question, you can always ask in the comment section on YouTube or in the chat option on the app. So we will be happy to answer whenever whatever we will share with you. So the question number 1 is, PNETs arise primarily from ductal epithelial cells, acinar cells, islet cells of Langerhans, or pancreatic stellate cells. The answer is C, pancreatic neuroendocrine tumors. Basically, the neuroendocrine neoplasm arising from the endocrine islet cells, they differ biologically and clinically from ductal adenocarcinomas. PNETs account for approximately what fraction of all pancreatic tumors? Answer is C. PNETs are rare compared with the exocrine pancreatic tumors. Classical teaching is 1 to 2% of the pancreatic tumors are PNETs, the rest are PDAC. Most common functional PNET is, so answer is B. Insuloma is the most frequent functional PNET and commonly present with fasting hypoglycemia. The best classical triad for insuloma is, so the answer is C. Whipple's triad defines clinically significant hypoglycemia with neuroglycopenic autonomic symptom relieved by glucose. So during a supervised 72-hour fast, the biochemical pattern supporting insuloma is, so the answer is B, that endogenous hyperinsulinemia shows inappropriately high insulin and high C-peptide when glucose level is low. This is an important question. Factitious hypoglycemia due to exogenous insulin typically shows. So the answer is B, that injected insulin raises insulin but suppresses the endogenous secretion, leading to low C-peptide and low proinsulin level. So that is the catch, that in endogenous hyperinsulinemia, both the insulin and C-peptide proinsulin level will be high. The rule of 10 for insulinoma most appropriately means, so it is basically, answer is B, and it is not a rule, it is an exception. Multiple insulinoma should prompt evaluation for, answer is B, ME1 syndrome. Multiplicity strongly suggests ME1 association, parathyroid, pituitary, pancreatic endocrine tumors. Gastronoma cause symptoms mainly due to, so answer is B, excess gastrin lead to hypergastrimia, marked acid hypersecretion, that is refractory and multiple ulcer, diarrhea and malabsorption. Most sporadic gastromas are located in, we have already covered all these questions, all the questions that were asked, I have already answered in my video. So answer is B. The gastronoma triangle or the Pissarro triangle concept indicates, answer is B, region where 90% of gastroma arise. Most gastroma occur within the anatomical gastroma triangle, classical surgical anatomy. Best single differentiator of gastroma versus other cause of hypergastremia is, so again we have already discussed, the answer is B, gastroma, high gastrin, high acid, low pH, atrophic gastritis, and BPI, high gastrin but low acid and higher pH. Hypergastrinemia with the low gastric acid output is most consistent with, we have just discussed. Answer is B, atrophic gastritis oblique pernicious anemia, parietal cell loss, achlorhydria, compensatory hypergastrinemia. Secretin stimulation test in gastronoma classically shows. So answer is C. Paradoxical increase in gastrin after secretin supports gastronoma used when fasting gastrin is equivocal. Pipoma syndrome is best remembered as, it's simple. Answer is A. WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. That is the Werner-Morrison syndrome. BIP causes watery diarrhea mainly by. So answer is B. Increase basically intestinal cycle AMP that leads to secretory diarrhea. A key clinical clue suggesting secretory diarrhea, that is Bipoma or Werner-Morrison syndrome or WDHA syndrome is. So answer is B. Secretory diarrhea continues during fasting. Osmotic diarrhea improves. So this is the one of the hallmark of the Werner-Morrison syndrome. Glucagonoma is classically associated with. So you cannot forget that picture of NEGM. The answer is A. Necrolytic migratory edema plus diabetes and weight loss is hallmark. So at diagnosis, glucagonoma most commonly has. Answer is C. Most of the glucagonomas present late and they have liver mets at presentation. The classical triad with somatostatinoma 3S includes. So answer is A. Stone, sugar, steatorrhea. Somatostatin inhibits insulin GI excretion and leading to diabetes, steatorrhea, because the pancreatic inhibition and also gallstone from the reduced gallstone motility. So, all these things we have already discussed in the theoretical discussion of this video. This is a repetition. Next question is non-functional PNETs most commonly present with. So, answer is C. Non-functional PNETs lack a hormonal syndrome and are usually discovered very late with usually meds. A commonly used but non-specific marker for a non-functional NET is B. Chromoglobin A can be elevated but it is non-specific, can rise with PPI and renal failure. The best first-line imaging for localizing or staging of suspected PNET is. So B. CT scan oblique MRI. They detect hypervascular primary tumor or METs. PNETs are typically best seen on CT during which phase? So C. Arterial phase, because they are hypervascular, avid arterial enhancement is seen. They light up on the with contrast. Endoscopic ultrasound is most useful because it is. So B is the answer. It can detect very small lesion up to 2-3 mm and even tissue diagnosis is possible with USFNB. Again, similar question. A major advantage of US over CT MRI in PNET workup is. So answer is B. You can have a tissue diagnosis also along with the imaging. The gold standard functional imaging for somatostatin receptor expressing NET is. Come on. We have already discussed it. So answer is B. Gallium DOTA PET, DOTA NOx, basically DOTA based studies. They are high sensitivity specific for SSTR positive NET and is preferred over the older scintigraphy. Octoscan, that SRS old scan, works by. Answer is B. Binding to the somatostatin receptor with radio level the analog. Next, angiography can localize PNETs because they are. Next is on histophysiology. Neuroendocrine tumors classically show. C. Stippled or salt and paper chromatin is characteristic of the NETs. Most useful confirmatory IHC marker for NET includes. So B. Chromoglobin A and synaptophysin are the key neuroendocrine marker. Ki67 aids in grading. Do remember that. The WHO grading of well-differentiated PNETs are usually primarily based upon. So I hope you remember it's B. Ki67 proliferation index and mitotic count. Ki is less than 3 to 20 more than 20 and mitotic is less than 2 to 20 and more than 20. Pancreatic NET grade 1 defined by Ki67 less than. So less than 3% Ki and less than 2 mitotic count. Answer is A. A well-differentiated pancreatic NET with Ki67 more than 20% is. So we have discussed this in a table. So this answer will be B, well-differentiated NET grade 3 if the architecture is preserved. If the architecture is not preserved, poorly differentiated, then it will be NEC. Poorly differentiated pancreatic NEC is typically, come on, we have already discussed this. So NEC small oblique large cell 2 type is aggressive with poor prognosis and often needs systemic chemotherapy. They are usually not amenable for any surgical resection. Best overall curative option for localized PNET is, so surgery. Option B, resection is the treatment of choice for all localized disease. Approach depends on the size, site, grade and function. So whenever we can take out the disease, we have to offer them surgery. Enucleation is most appropriate for, remember the case we have discussed. So B, small tumor less than 2 cm, low grade, grade 1, grade 2 may be close to the surface. A key surgical criteria favoring enucleation is tumor distance from main pancreatic duct. We already discussed. Option B, must be 2 to 3 mm away from the PD. Close proximity to the MPD increase fistula risk. So intraoperative ultrasound helps define the duct relation. So tumor in the head of pancreas requiring oncological resection most often needs. Option B, that will be Whipple procedure. Tumor in body tail of pancreas requiring resection often needs. Option A, distal pancreatectomy, friends. So body tail lesion typically treated with distal pancreatectomy depending on the oncological context and may require splenectomy also. Most common metastatic site from PNET is liver. Option C, most common site on METs strongly impacts prognosis and strategy, whether single, multiple, single lobe, bilobar. A patient with metastatic SSTR positive well-differentiated PNET is candidate for. Again, we have discussed option B, PRRT, that is the peptide receptor radionucleotide therapy. Again, this is very good modality for the metastatic lesion where the surgery is not feasible. Somatostatin analog octreotide, lenalidomide are primarily used to, as I said, they are the cross inhibitors, static tumors. So they are control hormone symptoms and slow tumor growth in SSTR positive disease. Option B. Everolimus used in advanced PNET targets the mTOR pathways, friends. Everolimus is mTOR inhibitor used in progressive advanced PNETs. Sunitinib benefits advanced PNET primarily through. Option B, tyrosine kinase inhibitor, TKI inhibitor, anti-angiogenic. A commonly used modern chemotherapy regimen for advanced well-differentiated PNET is option B, Captam, that is capstamine and temozolomide, widely used in pancreatic NET, especially progressive and metastatic disease. Streptozocin-based chemotherapy in PNET is classically combined with option B, doxorubicin. So streptozocin and doxorubicin is classical regimen used in the historically in the advanced PNETs. Symptomatic medical therapy that reduce insulin release in insulinoma is, I hope if you are not able to answer it, then I'm really worried. Diazoxide, option A, inhibits insulin secretion from beta cell used for the symptomatic control of pre-op or even when inoperable. First line symptomatic control of acid hypersecretion in gastroma is, it is simple, high dose PPI, option B. Which hereditary syndrome is most strongly associated with pancreatic NETs? So ME1 has high penetration by pancreatic endocrine tumors. Other associations include DHL, NF1 and DSC, rare for the PNETs. So with that, friends, we have reached this end of this video. And I hope we have added some new insight, new knowledge to your existing vast knowledge. So thank you very much, friends. And we wish you a happy learning. And for an exclusive and early access to our premium high definition content, please download our app or join the channel membership. The link for everything is given in description of this video. So we will don't forget to like and subscribe to our channel. we will come up with more knowledgeable videos. Stay tuned. Happy learning.